Now, when somebody has a TIA and the symptoms go away, there can be a number of reasons for that. And here I'd like to just underline one of the reasons, and one of the possibly quite dangerous reasons. This is something called the transcranial Doppler. It's a way that we have by applying ultrasound to the skull using a fancy kind of ultrasound called TCD, where we can actually visualize blood flow through the brain. And this slide shows a series of 6 time boxes from the left across to the right. And in the first time box at 1302, the middle cerebral artery is completely blocked, and that's evident with the top panel where it's all black. There's no redness there. And as you move across to the right, suddenly gradually you begin to see this red signal kicking in. And that's the reemergence of blood flow into this person's brain over the course of 30 minutes. So this person has recanalized. The blood clot has spontaneously broken up, and blood flow is reestablished. Now, I say spontaneously because that's what happens with TIA. That particular image was obtained after giving somebody TPA. So they were given TPA, the clot buster, and the clot was broken up and flow was reestablished. So maybe that was a TIA too, but it was done iatrogenically. Now, when somebody has a recanalization like that, we think that they reocclude again in about 20% of cases. So the person who comes into your emergency room and gets better may get better because the clot has broken up, but because the vessel wall is roughened or for whatever reason, they can reocclude in about 1 in 5 cases. So that may be a reason why the TIA has turned into a stroke within the 2 days to 90 days, which I showed you in the very first slide. The other reason that people get better is not that the clot goes away, but they find another way of getting the blood to the action, and that's called collateralization. And so the blood can kind of go around the corner and come and refurbish flow to the endangered area. And the most memorable story, which I usually tell, is of a 19-year-old who came down to our unit who was fine. We sent her down for a blood test, and they phoned us in a panic because she'd become completely hemiplegic. We went down there to see her, and she was very pale and indeed very hemiplegic. We put her onto a bed, raised her feet, her blood pressure improved, and her hemiplegia went away. So at a blood pressure of 130/70, her collaterals were getting around the block and making things all right. But when she had her blood drawn and she got a little bit faint, her pressure dropped and she became profoundly hemiplegic. So just a good reminder that when somebody's in your emergency room, that dropping their blood pressure in the acute phase is not a good idea because those collaterals are very important. And finally, in talking about this whole acute cerebrovascular syndrome, I want you to bear this in mind. We're calling it ACVS, acute cerebrovascular syndrome, and you'll notice that that's not too different from ACS, acute coronary syndrome. If you look around your hospital and you look at the amount of resource that is applied to the management of acute coronary syndromes, at least at a hospital like ours, with coronary care units and step-down units and ACVUs and the like, you realize how much energy and resource is made available to look after that circulation. Think about the resources that you're applying to look after the cerebrovascular circulation, which I would argue is equally as important, and in fact maybe even a little bit more important, because without a brain, the heart has no value. At any rate, that's a plug from the other side of the neck. I'm going to jump to a prediction about how much of this TIA or mild ACVS there might be in our province. And I've divided it up into the different regions. And what I did was to take the data from the Oxford review, where they were counting everything that happened in a very meticulous fashion, and then use Oxford's population and just simply predict what we might see in our different regions. And for those of you in Northern Health, the numbers are the same as for Interior, so I apologize for not doing that one twice. So for VHA, with 750,000 people, we should have about 1,260 mild strokes and TIA. So those are people who are the walking wounded, able to make it into a clinic setting. And for Fraser, that's over 2,000, and coastal 2,500, and interior about 1,300. So there are about 7,300 patients a year who would have a bona fide TIA or mild stroke who would come into our emergency rooms. If we look at the data that we've currently trying to generate through the auspices of the BC Stroke Strategy, our estimate would be considerably lower than that. So when these very intense registries are done, they discover there's a lot out there. So those are the kinds of numbers that we, as the various regions in the province, should be trying to deal with. Now, a paper came out in, I think, 2007, where a group in Western Ontario put together all of the papers that looked at the different interventions in TIA and said, how much do you think we could reduce risk if we were to do everything? And they estimated that there could be as much as an 80 or 90% reduction in risk if you were to throw everything at TIA to do a good job of it.